Bismillahirrahmanirrahim. So today I'm going to talk about the problems with the PCR testing that is done for the COVID-19. So starting from here, what is the specificity of PCR that is done for the COVID-19 and what is the sensitivity? Well, the specificity is very high. Specificity for the COVID-19 regarding the PCR is high. It means if the PCR is positive for COVID-19, it means it is true positive. The false positivity is very low. It is true positive when the person is having COVID-19, whether symptomatic or not, whether mild, moderate or severe, I have discussed in a previous lecture. But if it is positive, it means specificity is high. It means person has a COVID-19 infection. But what if it is negative? Negative PCR has low sensitivity. Low sensitivity means if it is negative, it cannot rule out COVID-19 infection. And we have seen a lot of patients, the PCR is negative again and again, but the person is clinically, radiologically, hematologically and biochemically COVID-19 infected. Now the second problem is that the PCR we do for COVID-19 is qualitative or quantitative. The answer is qualitative. It can tell you whether there is RNA or not. It does not tell about you the viral load. It does not tell about viral load. That is very high pitfall with that. Now what is the mechanism of this? It does not tell you whether the PCR that it has detected, it is living RNA lying in the person's nose or throat or the lungs, or it is dead RNA. What it does, it takes only the pieces of RNA and amplify those pieces and detect the RNA is detected. What happens when a person comes out of the infective period, that is the first week or the first 10 days, the RNA is still there in the form of dead pieces, But if you take the sample, it amplifies those dead pieces. It amplifies those pieces of RNA. It does not amplify the whole infectious RNA. It just takes part from that and the PCR amplify those pieces. So it does not tell whether the whole viral RNA are just pieces, because there is a difference. If we amplify, because if there is a whole viral RNA, person is infectious, you cannot break the isolation, but they have now made the SOPs of isolation. A person can break the isolation after 10 days of infection. Keeping in view this pitfall of the PCR testing, it cannot tell you whether the PCR has amplified the whole RNA or just the pieces of it. The second pitfall was already discussed, does not tell about the viral load. But how can you predict viral load is high? From the symptoms and from the inflammatory markers. If the inflammatory markers are high, it is the indirect clue of that the viral load is high. Coming toward the testing, 2/3 of the nasopharyngeal swab, if you take even with a good technique, with a good preservation and with a good machine, 1/3 are negative. Only 2/3 are positive, the nasopharyngeal. The 1/3 of the oropharyngeal are positive, 2/3 are negative. And here we do most of the test on the oropharyngeal because we do not have nasopharyngeal swabs. So that is another pitfalls. So if your suspicion is high, you can repeat the test again. The highest sensitivity that is seen so far is from the bronchoalveolar lavage or tracheal aspirate. But what if that is not possible? You can send the sputum, and the sputum can tell you, not saliva, sputum. Sputum can tell you about that. If ball or tracheal aspirate is not available, unfortunately nowadays procedures are shut down due to COVID-19 infection, and all the staff has been infected and they are at risk of getting infection because of the aerosol generation. And the highest sensitivity of the PCR testing is in first week. So summarizing the whole thing, specificity is high, sensitivity is low, does not tell you about the viral load, tell you about this is only qualitative PCR, just like the PCR for hepatitis C. You are having the PCR positive, the qualitative, but the qualitative PCR does not tell you about the viral growth. For that you have to go for quantitative PCR, and that actually is a game changer. That from that you decide whether I have to treat the patient or not. If treat the patient, how far should I go aggressively? So, and it does not tell you about the actual infectious RNA or just a pieces of RNA. So after 10 days you can break the isolation. RF2 PCR are negative 24 hours apart, you can break isolation. Or there was another criteria, that is 72 hours after the improvement of the symptoms. Thank you for watching.